The indications of arthroscopy can be classified into various ways. We can classify, the indications like classical and extended indications, or we can go by anatomy as well, by say ligament injuries or meniscal pathologies or cartilage, patella and synovium, or the other way is going by the pathology itself, whether it's traumatic or infection or tumors or inflammatory arthritis and so on. The other way to go about is diagnostic, therapeutic and palliative. So I'm going to make a little mix of all this, and let's go very quickly for the youngsters and the PGs, the ligament reconstructions and avulsion fixations. So ligament injuries, especially ACL, PCL, avulsion and reconstruction. We nowadays also do popliteus reconstruction arthroscopically, and of course MPFL as well. We've done few cases of popliteus avulsion fracture fixations from the femoral side as well. Meniscus, I think we had a wonderful lecture, so I need not go into all this, but there is an indication for cyst excision and repair of the cyst, the meniscus. And of course, meniscal transplants are also coming in big way, and people are doing it arthroscopically. Cartilage injuries, osteochondral fracture fixation, osteochondritis dissecans, abrasion orthoplasty or microfractures, mosaic or oats. And of course, the ACIs are also nowadays done arthroscopically. Synovitis is very commonly seen in our clinical practice, and rheumatoid arthritis not responding to medical line of treatment, we go ahead and do an synovectomy. Vilonodular synovitis, again, we see sometimes in our practice, and we do have to do this. Apart from this, at times it's a good advice to go ahead and do a retrium intraarticular injection to prevent recurrence. Chondromatosis, chronic non-specific synovitis, very rarely gout, although not really indicated, but I have found synovitis not responding, and I went inside and that was classical gout. Infections, tuberculosis or septic knee, revision ACLR infections can also be managed arthroscopically. Infected TKR, and especially the patient is not very fit and we just want to do a washout. So this is one of the cases which we did in total knee replacement. We did an arthroscopy and arthroscopic washout. You can see that insert, poly insert, and you can see the metal implant there. And one has to be doing this very, very thorough synovectomy and of course insert a drain and do whatever else is required. This is a Dias procedure. And of course, we also use arthroscopy in infected cases. So when we do a revision case and it's an infection case, we go down arthroscopically, debride it, open up the tunnels, and we also put in antibiotic beads there into the tunnels, femoral and tibial, both sides, and that can be done arthroscopically. Osteoarthritis, not very classically done, but especially all the HTOs, I would do a scopy, and if there is a root tear, I would rather repair it. And if it's an extruded one, I centralize the meniscus. People do arthroscopy to evaluate the cartilage of the patellofemoral joint and the other cartilage, especially in unicondylar knees, but I have no experience with that. If there are mechanical symptoms, very rarely we do OA. In OA, we do arthroscopy, but not routinely advised. Fractures, of course, we do ACL, PCL, avulsion fracture fixations. As I said, the avulsion fracture of the popliteus also we nowadays fix it. Arthroscopic assisted tibial plateau fractures, mind you, there is a chance of extravasation and compartment syndrome, so we have to be very, very quick. Fixations of osteochondral fractures and loose body removal. Patellofemoral joints for diagnosis of maltracking, lateral release, nowadays not very, very routinely done. MPFL reconstructions can be done by arthroscopic assisted surgery, and that is one of the cases here what we have done. Chondral lesions like BMAC, ACI fixations are also done. And people do a patella ACI in prone position, totally arthroscopic with air insufflation or CO2 insufflation. Patella spurs can be easily removed arthroscopically. Nodules and tumors like cyclops nodule, not necessary, it is always with an ACL tear. Patella Klunk syndrome, as in case of TKR, ganglion cyst, synovial cyst, ACL myxoid degenerations, meniscal cyst, as I spoke already, osteochondromatosis and hemangiomas, all can be dealt arthroscopically. We also use arthroscopy for revision ACLR patients, cases, and of course implant removal. Now this was one of the case, and you can see there is a Herbert screw which is very, very prominent and hurting the cartilage, and we could arthroscopically go down and remove that. We also do something called as bone grafting arthroscopically for the ACL revision cases. And this is one of the case. You see the first two pictures are showing the bone graft, which is completely healed. The ACL endo button of the first surgery is there. And then we did a second surgery with the second endo button in the anatomic position, a bioscrew and a suture post as an additional fixation. And in spite of having two-stage surgeries, so total 3 surgeries, he has an excellent range of motion. So even in revision cases for bone grafting, for infected revision cases, we go ahead and do arthroscopically. This is not a very common indication, but if the patient has a huge bursa, we have to, of course, deal with the intra-articular pathologies, but also we can do a bursoscopy. So you see this, there is a needle going in the posterior aspect. The bursa has been aspirated. I inject methylene blue into it, go into the posterior middle compartment, open up the mouth of the bursa, drain the bursa, and you see the needle coming from the posterior popliteal into the cyst. And you put in a shaver, debride it, and you see my whole scope is inside the joint, right from anterior intercruciate into the bursa, and we can do something called as bursoscopy also. Although not routinely advised, we should always deal with the intra-articular pathologies and open up the bursa or mouth arthroscopically. Conservative versus surgery. So do all ACL tears, now this is a second topic which has been given to me, so I'll quickly switch to the other topic. Do all ACL needs surgery? Do all ACLs can be managed conservatively? And if certain ACLs need surgery, when and which are the ones? So professional sportsmen, yes. Pivoting activities, if the athlete is involved in pivoting activities, turning activities, yes. Now these are two papers. Mild to moderate physical activity. Now, Frobel et al. Is a level 1 evidence. 50% will not need surgery if treated by structured rehabilitation protocol. This is very, very important. Just don't leave the patient. Give him a rehab protocol. Newman et al. 100 consecutive cases at 15 years, 77% did not need surgery. Of course, it means that they have done the structured rehabilitation protocol. Age is not the criteria, and an active lifestyle is not an indication for surgery. Now, there are papers also, there are a lot of contradictory papers, certain supporting, certain are against. And this is one of the papers which suggests that there is a lot of incidence of OA if there is an ACL deficiency. So the first paper at OA at minimum of 10 years, they showed 20.3% having grade 3 and OA with ACL deficiency versus the 4.9 in the opposite side. Meniscal tear, this is another paper by Church et al. ACL earlier, within 12 months, if you operate, the incidence is just 41.7%, late 71.2%. But then there is another paper which is contradictory to this, but this is a level 1 paper, very high quality paper, and they suggest that there is no difference in prevalence of OA in patients treated with rehabilitation, whether it is early ACLR or delayed ACLR. However, the prevalence of patellofemoral OA was higher in their series, especially with patellar tendon graft. Now, the conclusion is mid-term 5 years, no difference in meniscal surgery rates, radiographic OA, or all functional scores in young active patients treated with early rehabilitation, early ACLR, or delayed. So all of these showed no difference. At 15 years, even the outcome without surgery was good, and there as compared to the surgical and non-surgical groups. Now, indications, what I do usually is surgery is, of course, we do it in all elite athletes who cannot alter their activity, in patients who have recurrent giving away sensation in spite of adequate rehabilitation, ACL tear with meniscal injury, multi-ligament injuries, and 50% of this is another paper to back it up, where 50% of the young active patients will need a delayed reconstruction, only 50% active young people. While the general population, it will be just 23%, they may need surgery in the delayed period. So acute, now another question which comes up is, what is the earliest time we can do our ACL reconstruction? Certain people say, should we wait for a couple of weeks and let it rehabilitate, get a range of movement, let the edema subside, let the bone bruises subside? Well, this is a wonderful meta-analysis where they said acute ACLR can be done within 8 days without having any complications like stiffness and pain and so on and so forth. And this is level 1 evidence. So we can straight away go and do a surgery. Of course, assuming there is no fractures, assuming that the other, the vascular injuries and the other injuries have been taken care of. Graft choices. This is the third topic I've been given. So it's a big thing to cover up in a short period of time, but I'll quickly try to cover it up. So we can classify the grafts as allograft and the autografts. And allografts nowadays are available. And I think one of the labs in South India is also now giving this, and it's easily available. Autograft, of course, is the bone patella tendon bone graft, hamstring, quadriceps, and peroneus longus graft, which is getting very popular nowadays. So bone patella tendon bone still remains the gold standard in athletes and young adults. Bone plug on either side, so excellent healing in the tunnels, excellent fixation with good screw fixation. Sufficient length is available and the width as well. But there are some issues with this graft. Kneeling, there are kneeling problems. People cannot kneel because of the scar. Weak quadriceps mechanism, fracture of the patella can occur rarely. Impingement due to osteophytes. And there is an incident. There are certain papers who say that there is a contralateral ACL tear, and which has a high incidence in these people who have patellar. You've taken the patellar tendon graft. High incidence of patellofemoral OA as well. Watts graft is also now getting very, very popular. It's a nice, thick, strong graft. You can have it as long as 80 mm or even 90 for a PCL. It can be used as for single bundle and double bundle ACLs and PCLs. It's wonderful for double bundle PCL. It can be harvested with a bone plug. It's very popular in young and pivoting injuries. That is shown in a comparative study with other grafts that it is excellent in young and pivoting injuries. The graft morbidity and quadriceps weakness is a disadvantage. Hamstring is very, very popular, and most of the surgeons today prefer it because there is very minimal graft site morbidity. The hamstring regains its strength by almost 95%. It's a better technique. Fixation options are multiple, quick and cosmetic. Kneeling possible is possible. There's no issues with that. There is no issue with the fracture patella. However, there is a re-rupture higher rate in 15 to 20 years females. But about 20 years, males or females, there is no incidence of high re-ruptures in hamstring tendons. The graft size should be, minimal, 70-20 in the femur, 25 in the joint, and 25 in the tibia. The graft size is directly proportional. The re-rupture rates are directly proportional to the width. So the bigger the width, the better the stability and lesser the chances of re-rupture. Peroneus longus is becoming very, very popular, and nowadays we don't suture the peroneus brevis with the longus. Just take the peroneus longus with a very small incision, and it gives a very robust graft, very quick to prepare, and gives excellent results. And there are a lot of literature to suggest that there is not much issue with the ankle and the first ray plantar flexion and etc. So this is another systematic review wherein it's a level 1 study wherein they have studied almost 3,992 patients and they've suggested that the Aikidesi, Lislom, Lignor, the Tignor score with BTB, quadriceps and hamstring, they had no difference. But the Lachman score was best with BTB, and the pivoting was the best with bone patellar tendon bone graft, followed by quadriceps and followed by hamstring. Thank you indeed. Thank you so much for your patient listening.